Good afternoon, our dear students, and the topic of our lecture is hemophilia and thrombocytopenic purpura. Hemostasis is a dynamic process in which the platelet and the blood vessel wall play key roles. Platelets become activated upon adhesion to the one Willebrand factor and collagen in the exposed subendothelium after injury. Platelet activation is also mediated through shear forces imposed by blood flow itself, particularly in areas where the vessel wall is diseased, and is also affected by the inflammatory state of the endothelium. The activated platelet surface provides a measure of physiologic site for coagulation factor activation, which results in further platelet activation and fibrin formation. Genetic and acquired influences on the platelet and vessel wall, as well as on the coagulation and fibrinolytic systems, determine whether normal hemostasis or bleeding or clotting symptoms will result. Platelets are released from the megakaryocyte, likely under the influence of flow in the capillary sinuses. The normal blood platelet count is 150 450 nanoliter. The major regulator of platelet production is the hormone thrombopoietin, which is synthesized in the liver. Synthesis is increased with inflammation and specifically by interleukin 6. TPO binds to its receptor on platelets and megakaryocytes, by which it's removed from the circulation. Thus, a reduction in platelet and megakaryocyte mass increased the level of TPO, which then stimulates platelet production. Platelets circulate with an average life span of from 6 to 10 days. Approximately 1/3 of the platelets reside in the spleen, and this number increases in proportion to splenic size. Normal vascular endothelium contributes to preventing thrombosis by inhibiting platelet function. When vascular endothelium is injured, these inhibitory effects are overcome, and platelets adhere to the exposed intimal surface primarily through IVth factor and large multimeric protein present in both plasma and in the extracellular matrix of the subendothelial vessel wall. Platelet adhesion results in the generation of intercellular signals that lead to activation of the platelet glycoprotein 2B and 3A receptor and resultant platelet aggregation. Activated platelets undergo release of their granule contents, which include nucleotides, adhesive proteins, growth factors, and procoagulants that serve to promote platelet aggregation and blood clot formation and influence the environment of the foreign clot. During platelet aggregation, additional platelets are recruited to the site of injury, leading to the formation of an occlusive platelet thrombus. The platelet plaque is stabilized by the fibrin mesh that develops simultaneously as the product of the calculation cascade. The concept of a stepwise process and cascade of the calculation system was first described in 1964. While this traditional model described two separate pathways, the intrinsic and the extrinsic pathway, which culminate in a common pathway. Current views support an interconnected relationship between the two. The contact pathway is composed of three zymogens: plasma, kallikrein, and high molecular weight kininogen. In vivo, the activation of factor 12 at the start is still under discussion, so that current studies consider tissue factor. A transmembrane glycoprotein expressed in perivascular tissue to be the main initiator of in vivo blood clotting. Coagulation cascade is activated by two pathways, the extrinsic and intrinsic, which culminates into a common pathway. The extrinsic pathway is thought to be the more important pathway as regards clot formation. It's primarily responsible for the formation of large amounts of thrombin. Damage to blood vessel endothelium leads to a release of tissue factor. Tissue factor has multiple effects, including the activation of factor 7. The tissue factor and factor 7 complex activated factor 10. Factor 10, along with another cofactor, activates thrombin. Thrombin has a variety of effects and by itself is sufficient to amplify, propagate the coagulation cascade. However, the most important functions of thrombin are activation of fibrin and activation of factor 8. Fibrin is primarily responsible for hemostatic plaque formation, while activated factor 8 initiates covalent bonding of fibrin. During this time, the intrinsic pathway is also activated. The intrinsic pathway provides cofactor support and involves mostly intravascular compounds. The prothrombin time and international normalized ratio reflect the extrinsic pathway, while the partial thromboblastin time reflects the intrinsic pathway. Factors 2, 7, 9, and 10 require calcium and phospholipid for activation. These are vitamin K dependent coagulation factors and affected most by liver disease and warfarin. Extrinsic pathway is affected and hence PTI and R is elevated. Normal PT is from 12 to 16 seconds. Prothrombin time and international normalized ratio are same thing. Antithrombin 3 inhibits factor 2A and factor 10. Tissue plasmagen activator like streptokinase converts plasminogen to plasmin. Plasmin degrades fibrin and tissue plasminogen activator are used as thrombolytics or fibrinolytics. Factor 12, is the only protein in the coagulation cascade whose deficiency does not cause bleeding, but rather results in a prothrombotic state. Laboratory investigations include blood count and film, show the number and morphology of platelets, and any blood disorder such as leukemia or lymphoma. The normal range for the platelet count is 150 400 of liter. Bleeding time measures platelet plaque formation in vivo, normally between 3 and 10 minutes. Prolonged bleeding times are found in patients with platelet function defects. And the bleeding time taken for a standardized sensory skin picture to stop bleeding. Measures platelet plaque formation in vivo, normally between 3 and 10 minutes. Prolonged bleeding times are found in patients with platelet function defects. Coagulation tests are performed using blood collected into citrate, which neutralized calcium ions and prevents clotting. The prothrombin time, the partial thromboplastin time, the thrombin time, correction tests, factor assays, special tests of coagulation. Coagulation test. The prothrombin time include measures clotting time of plasma after adding thrombin. Normal clotting time is 16 seconds. Prolongation thrombin time results from deficiency of fibrinogen and dysfibrinogen anemia. The partial thromboplastin time needed for the plasma to clot in the presence of surface activator, kaolin, cephalin, and calcium. Normal time of clotting is 30-40 seconds. Prolonged PPT results from deficiency of factor 5, 8, 9, 10, 11, prothrombin and fibrinogen. Thrombocytopenia. Thrombocytopenia results from one or more of three processes. This decreased bone marrow production, sequestration, usually in an enlarged spleen, and or increased platelet destruction. Disorders of production may be either inherited or acquired. In evaluating a patient with thrombocytopenia, a key step is to review the peripheral blood smell and to first rule out pseudo-thrombocytopenia, particularly in a patient without an apparent cause for the thrombocytopenia. Thrombocytopenic purpura includes two classes: thrombotic thrombocytopenic purpura and immune thrombocytopenic purpura. Thrombotic thrombocytopenic purpura is congenital, is a result of a mutation of a gene responsible for desynthesizing Adams 13, and idiopathic or autoimmune, where antibodies directed against Adams 13 are created. Immune thrombocytopenic purpura can be acute and chronic. Acute is the most common form of ITP. We see this type most commonly in young children, ages 2 to 6 years. Characteristics of acute ITP include symptoms that follow a viral illness, such as chickenpox, Very sudden onset, symptoms that disappear in less than 6 months. Treatment is often not needed, and the disorder usually does not occur. Chronic thrombocytopenic purpura characterized adults have this type of ITP more often than children, but it does affect adolescents. Characteristics of chronic ITP include the disorder can happen at any age. Symptoms can last a minimum of 6 months, several years, or even a lifetime. Women develop it 2 to 3 times more often than men. It can recur often and requires continual follow-up care with a blood specialist. Immune thrombocytopenic purpura was previously known as Ideopathic Thrombocytopenic purpura. The term idiopathic no longer applies because the etiology is known. ITP is caused by dysregulation of the immune system. The term purpura has been abandoned because it's misleading. Almost 1/3 of patients with newly diagnosed ITP have no bleeding despite their low platelet counts. In adults, most cases of ITP are chronic, manifesting with an insidious onset and occur in middle-aged women. This clinical presentation suggests that the triggering events may be different. In chronic ITP, for unknown reasons, membrane glycoproteins on the surface of platelets become immunogenic, stimulating the production of platelet autoantibodies. In acute ITP, their stimulus for autoantibody production is also unknown. In persons with chronic ITP, approximately 75% of autoantibodies are directed against platelet GB2B and 3A complexes. The annual incidence of immune thrombocytopenia is estimated to be 5 cases per 100,000 children and 2 cases per 100,000 adults. Spontaneous or accidental trauma inducted intracranial hemorrhage is the most frequent cause of death in association with ITP. In middle-aged adults, women are affected more frequently than men. The factors that initiate autoantibody production are unknown. Antibody-coated platelets bind to antigen-presenting cells through factor epsilon receptors and are then internalized and degraded. Antigen-presenting cells not only degrade glycoprotein 2B3A, thereby amplifying the initial immune response, but also may generate cryptic epitopes from other platelet glycoproteins. Activated antigen-presenting cells express these novel peptides on the cell surface along with costimulatory help and the relevant cytokines and facilitate the proliferation of the initiating CD4 positive T cells clones. and those with additional specificities, T-cell clone 2. B-cell immunoglobulin receptors that recognize additional platelet antigens are thereby also induced to proliferate and synthesize anti-glycoprotein 1b9 antibodies. In addition to amplifying the production of anti-glycoprotein 2b3a antibodies by B-cell clone 1. A clinical picture of immune thrombocytopenic purpura. ITP is a primary illness occurring in an otherwise healthy person. Signs of chronic disease, infection, wasting, or poor nutrition indicates that the patient has another illness. Vital signs: hypertension and bradycardia may be signs of increased intracranial pressure and evidence of an undiagnosed intracranial hemorrhage. On cardiovascular examination, distant low amplitude heart sounds accompanied by jugular venous distension may be evidence of hemipericardium. On abdominal examination in children with acute ITP, the presence of a readily palpable spleen is not typical. In an adult, hepatosplenomegaly is also atypical for ITP and may indicate chronic liver or other diseases. In fact, splenomegaly includes the diagnosis of ITP. Laboratory studies. Laboratory testing for antibodies is usually not helpful due to the low sensitivity and specificity of the current tests. Bone marrow examination, the cellularity of the aspirate and the morphology of erythroid and myeloid precursors should be normal. The number of megakaryocytes may be increased. The peripheral blood smear may show large platelets with otherwise normal morphology. The morphology of red blood cells and leukocytes is normal. Clumps of platelets on a peripheral smear are prepared from ethylene diamine tetraacetic acid. Anticoagulated blood are evidence of pseudothrombocytopenia. Laboratory testing is performed to evaluate for secondary causes of ITP and should include testing for HIV infection and hepatitis C. Serologic testing for SLE, serum protein electrophoresis, immunoglobulin levels to potentially detect hypergammaglobulinemia, selective testing for immunoglobulin A deficiency or monoclonal gammopathies, and testing for Helicobacter pylori infection should be considered, depending on the clinical circumstance. If any anemia is present, direct antiglobulin testing should be performed to rule out combined autoimmune hemolytic anemia with ITP. Treatment of immune thrombocytic purpura. Corticosteroids remain the drugs of choice to the initial management of acute ITP, especially in the setting of life-threatening thrombocytopenia or when response in the platelet count is needed in an urgent or emergent setting. Treatment with corticosteroids may not only reduce the rate of platelets destruction, but may also rapidly alter endothelial cell integrity to facilitate primary hemostasis and to reduce bleeding and bruising. In adults, treatment is recommended for a platelet count less than 30 per liter. The ASH recommends that if treatment is needed, shorter courses of corticosteroids are preferred over prolonged courses. As first-line treatment, the guidelines suggest isoprednisolone or dexamethasone as the type of corticosteroid for initial therapy. Thrombopoietin receptor agonist and rituximab are second-line options for patients with ITP less than 3 months or more in those who are corticosteroid dependent or have the response to corticosteroids. For adults who have had ITP for longer than 20 months, splenectomy is also a second-line option. Intravenous immunoglobulin can be the drug of second choice for some patients, such as when a rapid increase in platelet count is important. Thrombocytopenic purpura is a rare blood disorder characterized by clotting is small blood vessels resulting in a low platelet count. In its full-blown form, the disease consists of the following pentat. Microanthropathic hemolytic anemia, thrombocytopenic purpura, neurologic abnormalities, fever, renal disease. Pathogenesis of thrombocytopenic purpura. The main histological finding in TTP is hyaline thrombi formed by platelet aggregation. These thrombi are responsible for capillary occlusion with subsequent ischemia in different organs. These thrombi consist predominantly of platelets with little fibrin and red cells compared with thrombi that occur secondary to intravascular coagulation. The von Willebrand factor plays a key role in platelet aggregation. Von Willebrand factor produced exclusively in endothelial cells and platelets is stored as Fibril granule in endothelial cells and as alpha granule in platelets. After being secreted, von Willebrand factor attaches to the endothelial surface. The longer this factor is, the greater the effects on platelet aggregation, because it's more related to the platelets IB receptor. 1B receptor, I'm sorry. The role of ADAMTS 13 is to split to von Willebrand factor in the smallest molecules. Regarding idiopathic TTP, findings show that it's an autoimmune process mediated by immunoglobulin G class antibodies. In the congenital form of TTP, Mutations in the gene encoding these proteins have been described. Item 13, activity levels of less than 10% are more clearly associated with idiopathic Ttp. Patients with Ttp typically report an acute or subacute onset of the following symptoms related to central nervous system dysfunction, anemia, or thrombocytopenia. Neurologic manifestations include alteration in mental status, seizures, hemiplegia, paresthesias, visual disturbance, and aphasia. Fatigue may accompany the anemia. Severe bleeding from thrombocytopenia is unusual. Also, petechiae are common. Clinical manifestation may also include the following. Fever occurs in approximately 50% of patients. Patients may notice dark urine from hemoglobin urea. Laboratory studies include complete blood count. Findings in patients with thrombotic thrombocytopenic purpura are usually as follows. Total white blood cell count is normal or slightly elevated. Hemoglobin concentration is moderately depressed at 8-9 gram per deciliter. Platelet count generally ranges from 20,000 to 50,000 nanoliter. Peripheral blood smears reveal moderate to severe schistocytes, I'm sorry. Prothrombin time and activated partial thromboplasmin time results typically are normal in both TTP and in hemolytic uremic syndrome. Also, some serious report patients with slight elevations of both tests. Dedimer and fibrinogen assay findings are as follows. Dedimers are indicative or of fibrinolysis and thus thrombin activation, which usually is normal or mildly elevated in patients with TTP. Fibrinogen typically is in the high to high normal range. Lactate dehydrogenase and bilirubin levels are indirect measures of the degree of hemolysis. LDH level in the 1000 IUL range is not unusual. Generally, a moderate degree of hyperbilirubinemia is present with the indirect form predominating. The direct Coombs test determines the presence of antibodies on red cells. Antibodies, if present, are more consistent with autoimmune hemolytic anemia. Because of the association of TTP has with HIV infection, serologic evaluation for this infection should be obtained in newly presenting patients. Imaging studies generally are not required in the evaluation of patients for TTP or HAS. In patients where stroke is suspected, CT or MRI scan may be performed to rule out infarct and or hemorrhage. Treatment of thrombotic thrombocytopenic purpura. The presence of microangiopathic hemolytic anemia and thrombocytopenia is the absence of other obvious causes is justification to begin total plasma exchange, preferably within 4-8 hours, according to British TTP guidelines. Plasma exchange with fresh frozen plasma is the therapy of choice for TTP. Replacement with normal saline and albumin is not adequate. Usually, at least 5 plasma exchanges are performed in the first 10 days. In patients whose TTP is refractory to plasma exchange, using cryopoor plasma has sometimes led to a response. Corticosteroids are commonly given to patients with TTP. The use of aspirin and dipyridamole, also part of standard therapy in the past, has fallen out of favor. Incretin alkaloid, generally used as chemotherapy, also has been shown to be useful in refractory cases. Heparin-induced thrombocytopenia can occur after exposure of low molecular weight heparin and as infractionated heparin. Also, it's more common with the latter. It occurs before 5 days in those who were exposed to heparin in the prior few weeks or months and have circulating anti-heparin antibodies. Rarely, thrombocytopenia and thrombosis begin several days after all heparin has been stopped. Heparin-induced thrombocytopenia antibodies can be detected using 2 types of assays. The most widely available is an enzyme-linked immunoassay with P factor 4 polyadenine complex as the antigen. Because many patients develop antibodies but do not develop clinical heparin-induced thrombocytopenia, the test has a low specificity for the diagnosis of this thrombocytopenia. In patients diagnosed with this disease, imaging studies to evaluate the patient for thrombosis are recommended. Early recognition is key in treatment of heparin-induced thrombocytopenia. Is prompt discontinuation of heparin and use of alternative anticoagulants if bleeding risk does not outweigh thrombotic risk. The direct thrombin inhibitor argatroban is effective in this thrombocytopenia. The DTI pivalerdin and the antithrombin binding pentasaccharide fundaparinux are also effective but not approved. Hemophilia is an X-linked resort hemorrhage disease due to mutations in the F8 gene or factor 9 gene. Hemophilia C, also known as plasma thromboplastin antecedent deficiency of Rosenthal syndrome, is a mild form of hemophilia affecting both sexes due to factor 11 deficiency. The disease affects 1 in 10,000 males worldwide in all ethnic groups. Hemophilia A represents 80% of all cases. Male subjects are clinically affected. Women who carry a single mutated gene are generally asymptomatic. Family history of the disease is absent in 30% of cases, and in these cases, 80% of the mothers and carriers of the de novo mutated allele. The frequency of hemophilia A is 1 per 5,000 live male births, whereas hemophilia B occurs in 1 in 25,000 live male births. Inheritance is X-linked recessive, leading to affected males and carrier females. Testing is indicated for male infants with a hemophilic pedigree who are asymptomatic or who experience excessive bleeding, or for an otherwise asymptomatic adolescent or adult who experiences unexpected excessive bleeding with trauma or invasive procedures. Hemophilia C is also primarily inherited, but it does follow an X-linked pattern because the mutation that causes it affects a gene found on chromosome 4 affects both genders equally. Orange disease or parahemophilia, in congenital deficiency or of factor V that is associated with hemorrhagic diathesis and abnormally slow clotting time. The severity of bleeding symptoms is only partly related to the degree of factor V deficiency in plasma. The most common physical findings of factor V deficiency are chemosis, bleeding from mucosal surfaces, and pallor secondary to blood loss. Fresh plasma or fresh frozen plasma infusions are used to correct the deficiency temporarily and should be given daily during a bleeding episode. Hemophilia results from deficiency of factor 8 or 9. So the extrinsic pathway is normal. Bleeding manifestation is due to inadequate fibrinogenesis, inappropriate fibrinolysis. Very high levels of thrombin are required to activate thrombin activable fibrinolysis inhibitor that augments fibrin deposition by inhibition fibrinolysis. Clinically, hemophilia A and hemophilia B are indistinguishable. Patient with hemophilia may present with easy pushing, inadequate clotting, or traumatic or even mild injury. Or in the case of severe hemophilia, spontaneous hemorrhage. Signs of hemorrhage include the following: general weakness, orthostatic tachycardia, tachypnea, musculoskeletal tingling, cracking, worms, pain, stiffness, and refusal to use joint. So, headache, stiff neck, vomiting, lethargy, irritability, and spinal cord syndromes. Gastrointestinal, hematemesis, melena, frank red blood per rectum, and abdominal pain. Other epistaxis, oral mucosal hemorrhage, hemoptysis, dyspnea, and other. Systemic signs of hemorrhage include the following: tachycardia, tachypnea, hypertension, orthostasis. Organ system specific signs and symptoms of hemorrhage include the following: musculoskeletal tenderness, pain with movement, decreased range of motion, effusion, and warmth. Central nervous system includes abnormal neurologic exam findings, altered mental status, and meningismus. Gastrointestinal can be painless, hepatic splenic tenderness, and peritoneal signs. Genitourinary, bladder spasm, distension, pain, and costovertebral angle pain, and other. On the hemoglobin hematocrit, expect normal or low values. Expect a normal platelets count. On calculation studies, the bleeding time and prothrombin time are normal. Usually the activated partial thromboplasmin time is prolonged. However, a normal IVth does not include mild or even moderate hemophilia because of the relative insensitivity of the test. The IVth is significantly prolonged as severe hemophilia. Hemophilia A, laboratory confirmation of a factor VIII inhibitor is clinically important when a bleeding episode is not controlled despite infusion of adequate amounts of factor concentrate. For the assay, the IVth measurement is repeated after incubating the patient's plasma with normal plasma at 37 grad for 1-2 hours. If the prolonged IVth is not corrected, the inhibitor concentration is titrated using the Bethesda method. Ideally, the Nijmegen modification of the Bethesda inhibitor assay should be used to detect an inhibitor if the mixing test result is possible. Hemophilia B, usually von Willebrand factor levels are also measured. The combination of low factor VIII and low von Willebrand factor may indicate this factor deficiency as their primary diagnosis. And hemophilia C, a specific assay for factor 11 activity is necessary to confirm the diagnosis. Assay to other clotting factors, and platelet function may be needed to exclude a combined hereditary deficiency of factor 11 and other factors. The treatment of hemophilia A may involve prophylaxis, management of bleeding episodes, treatment of factor VIII inhibitors, and treatment and rehabilitation of hemophilia synovitis. Use of factor replacement products and other medications, including pain medications, is typically required. The treatment of hemophilia B may involve management of hemostasis, management of bleeding episodes, use of factor replacement products and medications, treatment of patients with factor inhibitors, and treatment and rehabilitation of patients with hemophilia synovitis. The unpredictable nature of bleeding is a concern of hemophilia C, especially in patients with partial deficiency. Bleeding episodes cannot be predicted on the basis of factors 11 levels alone. Thrombotic events are a risk in some patients who receive factor 11 concentrates, particularly those with pre-existing risk factors such as older age, known peripheral or central vascular disease, or morbid obesity. Ambulatory replacement therapy for bleeding episodes is essential for preventing chronic arthropathy and deformities. Home treatment and infusion by the family or patient is possible in most cases. Prompt and appropriate treatment of hemorrhage is important to prevent long-term complications and disability. Many recombinant factor VIII concentrates are currently available. Those calculations are directed toward achieving a factor VIII activity level of 40% for most mild hemorrhages, of at least 50% for severe bleeds, or prophylaxis of major dental surgery or measured surgery, and 80-100% in life-threatening hemorrhage. Hospitalization is reserved for severe or life-threatening bleeds, such as large soft tissue bleeds, retroperitoneal hemorrhage, or other internal bleeding, and hemorrhage related to head injury, surgery, or dental work. Treatment of patients with hemophilia ideally should be provided through a comprehensive hemophilia care center. These centers follow a multidisciplinary approach with specialists in hematology, orthopedics, dentistry, and surgery, nurses, physiotherapists, social workers, and related allied health professionals. Patients treated at comprehensive care clinics have been shown to have better access to care, less morbidity, and better overall outcome. Ambulatory replacement therapy for bleeding episodes is essential for preventing chronic arthropathy and deformities. Various factor 9 concentrates are available to treat hemophilia B. Fresh frozen plasma is no longer used in hemophilia because of the lack of safe viral alimentation and concerns regarding volume overload. Clear precipitate contains no factor 9 and is not appropriate for factor 9 therapy. Those calculations are directed toward achieving a factor 9 activity level of 30% for most mild hemorrhages of at least 15 percent for severe bleeds, or for prophylaxis of major dental surgery or major surgery. And 80 and 100% in life treatment hemorrhage. Non-transfusion therapy in hemophilia. Desmopressin, a vasopressin analog, or 1-diamino-8-D-arginine vasopressin is considered the treatment of choice for mild and moderate hemophilia A. DDAVP stimulates a transient increase in plasma factor 8 levels. DDAVP may result in sufficient hemostasis to stop a bleeding episode or to prepare patients for dental and minor surgical procedures. A test dose should be performed before prophylactic use. It can be intravenously administered at a dose of 3 microgram kilogram of body weight in the inpatient setting. Its peak effects is observed in 60 minutes. A concentrated DDAVP intranasal spray is available for outpatient use. Anti-Fibrinolytic drugs. Bleeding in the gums, gastrointestinal tract, and during oral surgery requires the use of oral anti-fibrinolytic drugs, such as aminocaproic acid or tranexamic acid to control local hemostasis. The duration of the treatment, depending on the clinical indication, is 1 week or longer. Tranexamic acid is given at doses of 25 microgram kilograms 3 to 4 times a day. EACA treatment requires a loading dose of 200 milligram kilogram, followed by 100 milligram kilogram per dose every 6 hours. Treatment of patients with inhibitors. Inhibitors are antibodies that neutralize factor 8 and can render replacement therapy ineffective. Inhibitors develop in relatively young children, usually within their first 50 exposures to factor 8. Rarely, inhibitors can develop in individuals without genetic hemophilia. These occasionally are responsive to immunosuppressive therapy. Factor 9 inhibitors are less common than factor 8 inhibitors. They occur found in only 1-3% of patients with severe hemophilia B. These inhibitors typically appear after the first infusions of factor 9 concentrate. Imicizumab is a first-in-class bispecific monoclonal antibody that performs the function of activated factor 8. Pringin activated factor 9 and factor 10 to restore the coagulation cascade, but is unaffected by factor 8 inhibitors. Recombinant activated factor 7 has become the first choice of bypassing agents. desensitization in non-emergency situation also may be feasible. Recombinant human coagulation factor 7A is indicated for the treatment of patients with bleeding episodes and for the prevention of bleeding in surgical interventions or invasive procedure in patients with inhibitors to factor 9. This therapy includes large doses of factor 9 along with steroids or intravenous immunoglobulin and cyclophosphamide. Concizumab is a subcutaneously administered monoclonal immunoglobulin G4 antibody that promotes thrombin generation by binding to tissue factor pathway inhibitor. TFPI is the primary inhibitor of the initiation of coagulation. Prophylactic treatment. The main goal of prophylactic treatment is to prevent bleeding symptoms and organ damage, in particular to joints. Hemophilia arthropathy that results from recurrent or target joint bleeding can be prevented by this method. Usually, hemophilia carries with factor levels of 15% of normal have not been considered to be a risk for bleeding. However, a wide range of values have been reported due to random inactivation of the X chromosomes. Therefore, it's important to measure the factor level of carries to recognize those at risk of bleeding and to optimize preoperative and postoperative management. During pregnancy, both factor 8 and factor 9 levels increase gradually until delivery. Factor 8 levels increase approximately 2 to 3-fold compared to non-pregnant women, whereas factor 9 increase in less pronounced. After delivery, there is a repeat fall in the pregnancy-induced rise of maternal gluten factor levels. This represents an imminent risk of bleeding that can be prevented by infusion of factors concentrate levels of 50-70% for 3 days and the setting of vaginal delivery and up to 5 days for cesarean section. In mild cases, the use of TTAVP and or Anti-Fibrinolytic drugs is recommended. Elderly hemophilia patients have more severe arthropathy and chronic pain due to suboptimal treatment and high rates of HCV and or HIV infections. Excessive replacement therapy should be avoided, and it's prudent to slowly infuse factor concentrates. Continuous infusion of gluten factor is preferable to bolus dosing in patients with cardiovascular risk factors undergoing invasive procedures. Dear students, thank you for your attention. Goodbye.